Rhinoplasty is an interesting operation because you either like rhinoplasty or as a plastic surgeon, you stay away from rhinoplasty.
Have you changed your technique in the last decade?
I have changed my technique in the last decade.
And you see a face, I know your brain works very, very fast. Do you automatically know what they need within 1 second?
There are some cases that are on the fence and you may sort of vacillate between should I do it open, should I do it closed?
Can I ask you about a closed? Because I find it fascinating.
A lot of it, again, comes with experience. You start seeing things through a different vantage point.
Where do you pick up these new techniques?
Constant lifelong learning,
How accurate are the on-table photos or results?
They'll have an idea that the surgeon basically attempted to give them the result that they were hoping for, and sometimes it gives peace of mind. Welcome back to another episode of Unfiltered. Today we're going to be talking to you about rhinoplasty, one of my favorite procedures. Nancy's going to ask me some questions and discuss a number of cases.
Let's just start off with that. Why is it your favorite procedure?
Well, rhinoplasty is one of the procedures that I've done probably as a center point of my career. It's been a hallmark operation of my entire practice. So when I started facial plastic surgery, rhinoplasty was probably the procedure I got busiest with fastest. Rhinoplasty is an interesting operation because you either like rhinoplasty or as a plastic surgeon, you stay away from rhinoplasty. If you like rhinoplasty, you sort of dedicate a big part of your career to learning. They call it, like you hear about in all sorts of careers, lifelong learning. Well, lifelong learning really applies to rhinoplasty, probably more than many other procedures. That operation has and continues to evolve and change over the last few decades that I've been in practice. Talking to some senior surgeons, people who trained me, they felt that they were changing their rhinoplasty technique almost every decade. So that makes it really interesting.
Have you changed your technique in the last decade?
I have changed my technique in the last decade, not disbanding or dumping or getting rid of a previous technique because I thought it was bad, because I think the techniques that I learned from previous surgeons, like my mentors, were great operations. But in certain specific cases, I've modified the technique that I use. I can tell you, in my opinion, there's been a couple significant changes in rhinoplasty over the last 20 years. Maybe I'll summarize it like this. There was endonasal or closed rhinoplasty, which I trained in, which meant that all the incisions were hidden, and it was called invisible rhinoplasty because there were no scars. And that operation I still do, but it used to be the majority of the operations I did. Now it's become probably 50% of the operations I do. And then there's open, or known as structural rhinoplasty, which is an operation where a small incision is made underneath the columella, the middle part separating the nostrils. So there's a small scar, it's usually imperceptible, and then we expose the entire nasal anatomy, and that allows us to do very precise maneuvers to change the shape of the nasal tip, the bridge of the nose, and narrow the nasal dorsum as well. Sometimes that operation has some benefits. I'll get into that in a second, through either closed or open approach, but it's sort of its own category. The newest techniques that have been implemented are called preservation rhinoplasty. I think I've briefly touched on this in previous podcasts. That's an operation where we're preserving the natural beauty of someone's bridge, but moving it in closer to the face without removing any of the top of the nose.
So you keep the bump. The bump just becomes lower?
Yeah, the metaphor that people talk about is in a building. If you were to do a regular nose job, you say have an 8-story building, and you're removing, say, the 7th and 8th story, making a 6-story building. In preservation rhinoplasty,
Take the basement.
Yeah, you can take out the basement, or not the basement, but the lower foundation, the bottom part, and let everything fall down. That's called the drop down technique. Or you can take out the 5th floor, just below the bridge, which is in some ways conceptually easier for people to understand that you're just dropping the bridge down by removing tissue just below the bridge, and you're preserving the natural configuration of the bridge. And the reason to do that is if someone's got a very bad septum, so you're working on the inside already. If someone's got a very complex crooked nose, it could be helpful. If someone really wants to have some subtle changes and likes their front on view but just doesn't like their profile, that'll try to mimic and maintain the natural elegance of a natural bridge if they like it to start. But it's got some limitations as well. Sometimes it could be unpredictable. It may not drop down as much as you hope. So different doctors are adopting it. I use it selectively. Some doctors have made it a big part of their practice. I probably say would use it 10 to maximum 20% of my patients based on what I think their goals are and also their preoperative anatomy.
I was going to ask you, when you walk in the room at a consultation and you see a face, I know your brain works very, very fast. Do you automatically know what they need within 1 second? Open, closed,
I'd say the
preservation?
majority of patients, we sort of arrive at a treatment plan pretty quickly. Most surgeons sort of have it quick in their head what they want to do for the patient. They have it in their mind's eye, say what the best approach would be. But there are some cases that are on the fence, and you may sort of vacillate between, should I do it open, should I do it closed? In some ways, it's easier if the surgeon has a more limited toolbox, I guess, because everyone's going to get an open rhinoplasty. I'd say open rhinoplasty became probably the more popular procedure over the last few decades, partially because it was easier to train people in open rhinoplasty.
So open means you make this cut and you lift it all up so everything's exposed.
Yeah, because it's easier to see the anatomy, there's some advantages to it, and it's also easier to teach, so it's become adopted as probably if you were to look at the number of surgeons doing open and closed, I'd say probably more younger surgeons are doing open rhinoplasty than when I trained, where more were doing closed, and I'm somewhere in the middle. I use both depending on the case. So for a nose that has a relatively nice nasal tip, but just as a bump on the nose, a closed endonasal rhinoplasty makes sense to me.
Can I ask you about a closed? Because I find it fascinating because I have seen you in surgery. I mean, you're working through these two small holes. Your instruments go up there. How do you feel, or what are you using to feel what needs to be done?
A lot of it, again, comes with experience. You start seeing things through a different vantage point. We also have a headlight, and we have sometimes loop magnification, so we can see a little bit better than you're seeing if you're observing the operation. The incisions may look small, but they often give pretty good access to certain parts of the nose, specifically the nasal bridge. I do think it's hard to teach that operation, but once someone learns it well, they may sort of feel like it's a good thing to have in their rhinoplasty toolbox. So I loved closed rhinoplasty. I think it's a very elegant operation. There are other advantages separate from the scar. You can see the result of your rhinoplasty on the table in some ways more accurately than you can see an open rhinoplasty result. Open rhinoplasty may look really good on the table and have more changes after the surgery as the nose goes through the healing process because you've dismantled it and put it back together. In the old days, one of the common sort of shortcomings of open rhinoplasty that I was seeing a lot in my practice were patients were having nice results from open rhinoplasty, but we're getting what's known as a hanging columella because surgeons were not shortening the nose enough, or they were adding a lot of cartilage in to support the tip to prevent it drooping after the operation, but then they were actually lengthening the nose inadvertently. So a hanging columella became sort of a problem with open rhinoplasty when I trained. People have developed newer techniques. So what I was going to get to, one of the newest techniques is something called a septal extension graft, which is a minor modification of what we used to do for patients, which was known as a septal strut or a medial crural strut, where we were putting cartilage just between the medial crura, which is the middle part of the nose, to support it. But it was free floating. It was like you could almost click it on the nose if you're removing the nose. So what a septal support graft or a septal extension graft is, it's actually a piece of cartilage taken from the septum and then added onto the front of the nose with sutures. So it's now a fixed piece of septum, making your septum longer, but it allows you to then reposition the medial crura, the bottom part of the nose, vertically, allowing you to rotate the nose vertically and rotate the tip up onto a very strong foundation. So it typically will not droop back over time, which a strut tended to do more often. So that's one of the big advantages. The other advantage of a septal extension graft is lengthening the nose in a case that needs it. And finally, and maybe a good procedure to add tip projection. So if a nose is actually small and too close to the face, a septal extension graft may allow you to lift the tip out and increase projection and rotate it relative to that new structure. So that's something that I added into my practice within the last decade. And I do think that it's useful in specific cases.
Where do you pick up these new techniques?
Constant lifelong learning, talking to colleagues, going to conferences, communicating with friends in the field. All those things I think are important. Like I may attend a rhinoplasty course once every 1 to 2 years to see what's new, if anyone's doing things differently. We did a cadaver course, which we participated in at the University of Toronto, teaching the residents. A group of us who are all friendly with each other will sometimes chat and show each other some techniques on cadavers and see if we all agree. But there is variability within rhinoplasty amongst how surgeons approach the procedure. There's more than one way to skin a cat, I guess you could say. So people sometimes have their own preferences. Yeah, but that's what makes it an interesting operation.
How accurate are the on-table photos or results? People often ask
how
after
accurate?
Surgery. How accurate is that? What their nose? They think if they see the on-table photo after surgery that they have an idea of what their nose is going to look like.
They'll have an idea that the surgeon basically attempted to give them the result that they were hoping for, and sometimes it gives peace of mind. But the nose does change a lot over the first year and a half. So, I tell patients these are just giving you a rough idea of what we created on the table. Specifically, if someone has a really big nose and you've made them have a nice slope, or you've lifted the tip a little bit, those are useful. But the on-table results also going to have some swelling, so the nose won't look exactly how it will turn out once all the swelling and things like that have settled down over time. Some surgeons squeeze the nose a lot, manipulate it a lot for photography to get rid of the edema of the tip. I was going to actually
say that. Yeah. So it's hard to say.
Yeah, so it's a little bit hard to say because it may fill up a little bit and then some scar tissue may form. So you may end up looking, oh, that looks amazing on table, and end up with a fuller tip than you'd hope for. And then it may settle down even months later. So again, it's something that's useful. We try to photo document as much as we can nowadays because patients do find it helpful.
Do you always have to break the bone?
Not 100% of the time, but probably I'd say 80% of the time.
And the reason why you do it?
Narrowing the bridge of the nose.
Okay, because you're taking off the tallest peak.
Taking off the peak, so if you don't move the bones in, you've created a new shape, and it may not look as nice. It may look good from profile, but you may have what's known as an open roof deformity, a wide nose. If you feel with your finger, someone who hasn't had their nose bones mobilized, you can almost feel the edges of the bone, and then a middle part, and then another edge of the bone. So when we move the bones in, we're able to take a pyramidal shape and recreate another pyramidal shape.
Is breathing always impacted?
Breathing can always be impacted. We quote patients roughly 5% of their breathing being impaired from nasal surgery because you're making the nose smaller. But we do whatever we can during the operation to optimize airways. Sometimes we have to go back after the rhinoplasty is fully healed and do some additional work on the airway to make sure that we haven't compromised it.
Surgery day is number 1. And then there's about 364 days that follow surgery as far as recovery. How do you navigate that with patients when, it's a long process and we explain it to them all the time? How do you navigate that with patients who may be struggling along the way?
Listen, we do our best to be available to patients to answer questions and to deal with any anxiety. I feel like the patients seem, I don't know, it goes in waves, but right now everyone seems pretty calm. And we've had like a really good wave with very happy patients and very few patients like flipping out or stressed out after surgery. But I think just our staff are trained well in dealing with the patients, being able to answer questions. A lot of it's just peace of mind and support. If patients need to be seen or come in, then we're available. Yeah. It gets tricky if patients are in another city and they've flown in for an operation. If they have a concern, then we do video FaceTimes and things like that just to check in on them. So I think staying available and communicating as much as possible, hopefully makes the patients feel supported.
And we do have patients come in from all across Canada, the United States, for surgery with us. How do you feel about being at this place in your career, 25 years in, and people travel from all over for you?
I guess it's humbling. I mean, you want to feel, you don't want to be... take it for granted. I think it's humbling and it's nice that you're getting, your name spread in a positive way, that people are seeking out your skill set that you've spent your career developing. So it certainly makes you feel some validation. So that's always nice. You know
what I'm finding? And it's happened a few times in the last few months where patients come in and the mom has said, well, he did my nose. And I'm like, wow, he's at that stage of his career.
We see that all the time now. I know, it's
right?
Crazy.
That's what's happening.
Those are nice stories, but we do see that all the time.
All these years later, the mom, what you did and changed the life of the mom, she wants that for her child, and I think that's really nice.
Yeah, no, it is very nice. I mean, it makes me feel like I'm getting older, but it is very nice.
What about ultrasound rhinoplasty? We do get inquiries about that. What is that?
So there's a tool called piezo. It's available. We have it, but we don't use it frequently. I think some surgeons really love it. It's almost like the scaling device that's used to clean your teeth. Some of the hygienists like to use the old-fashioned pick. Some like to use that water thing that basically has the high-frequency sound. There are some nice advantages to it. I find it easier to do with an open rhinoplasty. I find you're working through a bit of a tunnel if you're doing it through a closed rhinoplasty. But there's nothing wrong with it. I mean, some surgeons love it. Other surgeons stay away from it. I think if it was universally way better than other techniques, everyone would switch to it. And I think that it's probably still the minority of surgeons using it. The advantages are felt to be more precision. I'm not sure about that. It adds to surgical time. It's a bit slower. The ability to shape the bones rather than just break the bones, there's an advantage to it if someone's got asymmetric or strange shaped bones, where we'd be using files and rasps and chisels instead. This sometimes can sort of scrape the bone and smooth it out a little bit, which we would use a file or something like that to work with. So I don't have a problem with it. I think it's a nice device, but it does add surgical time, and there's more of a necessity for open rhinoplasty. So if you're doing a mixture of open and closed rhinoplasty, it may be that you would use it less often. So I have some colleagues who use it all the time. I have some colleagues who bought it and don't like it at all, and it sits on a shelf. They use it a little bit more like a marketing thing that they offer it. So nothing against it, but I wouldn't say that I've adopted it as part of my regular rhinoplasty.
The last thing I want to mention, it's a little bit of a PSA, and it's about complications that we do come across doing rhinoplasty. It's patients who call us, or potential patients who call us, asking about repairing a hole in a septum. So, I mean, that's a complication that comes from continuous or repetitive cocaine use, which isn't a good thing for the septum. How many times does somebody need to be doing cocaine to develop a hole in their nose like that?
It's a good question. I don't know the answer to it, but the reason that it occurs is because the cocaine is acting as a vasoconstrictive drug, making the blood supply limited to the cartilage of the nose. And if it's used frequently or chronically, it can lead to a perforation where there's a permanent hole between the sides of the nose chamber. Some people are aware of it. They hear whistling. Some people just get a bit of crusting of the nose. It doesn't mean if you have that it can be necessarily fixed. If it's a very large hole, it may be something that you can't fix, too hard to fix. Small holes can sometimes be closed, but if the patient's still going to be using the drug, then it makes no sense to operate on them because it'll likely break down. There's a chance you can make it worse with surgery. We do sometimes see patients with septal perforations who still want a rhinoplasty if the patient has convincingly told us that they have not used the drug since many years, like since they were in a party phase of their life, and they have other cartilage in the nose that looks like healthy, and they have a small perforation. We'll still offer them a rhinoplasty. There are some limitations, but we still will offer rhinoplasty. Some patients will come in with what's known as a saddle nose. The bridge of the nose starts to collapse, and we'll be rebuilding those by adding cartilage in. There are a couple doctors in Ontario who have a big interest in closing septal perforations. I used to do a lot of those. I'm too busy in my career to be focusing on that right now. And because there are some surgeons keen on it, I usually refer them to those doctors. Well, that was a lot of information. Hope you guys found that useful. And thanks so much for tuning into another episode of Unfiltered.